Okay, so this article takes as its starting point two things. Firstly, that human rights are universal and apply to sex workers, and secondly, that a great deal of the political and media discussions around human rights violations in the sex trade are not based in rigorous evidence. So to address this, we did a comprehensive review. We prioritized primary data published in the past 5 years, and we reviewed over 800 studies. We looked for three things. Firstly, the prevalence of human rights violations perpetrated against male, female, and transgender sex workers. Secondly, we looked for impact on HIV risk, infection, treatment, and care, quantitatively whenever possible. And here is an excerpt from a table showing how we brought the health and human rights data together. Lastly, we analyzed four common legal models according to evidence of human rights violations and HIV implications that we found in the review. So to begin, there were many violations by police reported across the literature, and one of these was police confiscating, destroying, or using condoms as evidence of a crime. When quantified, condom confiscation was found to be associated with unprotected sex. Furthermore, sex workers who are injection drug users also face the confiscation of sterile injection equipment, even where it is legally available. And the latter has been found to be associated with prevalent HIV and statistically associated with experiences of police-perpetrated sexual violence. Lastly, police extortion was a very common occurrence, itself linked to inconsistent condom use and STI symptoms. Police violence against transgender female and male sex workers was documented in multiple studies across many contexts. And while the range of reported physical violence by police varies widely, note that even the lowest range of 5% or 1 in 20 indicates a relatively high level of human rights violations occurring. Severe physical violence such as beatings, public whipping, and shocking with electrical rods in police detention were documented in 3 studies. As for sexual violence, again, the range varies widely. And again, even the lowest range is cause for large concern. Sexual violence was reported by a number of studies to occur specifically in the context of arrest and detention. In some instances, arrest served as a pretext to apprehend sex workers and drive them to an isolated location where violence occurred. Police violence is significantly associated with accepting more money for unprotected sex, inconsistent condom use, STI symptoms, and STI and HIV infection. A number of studies report very high levels of homicide for sex workers, and patterns of failure to investigate such killings are reported in many contexts. Many studies report significant levels of violence by non-state actors, such as perpetrators posing as clients or clients, intimate partners or spouses, and third parties. Of particular note here are the very high levels, between 39 and 100% of sex workers who reported that they did not consider they could report abuse to police. In some cases, this was attributed to police abuses, in others to an antagonistic relationship due to criminalization. Evidence from multiple studies indicates that perpetrators' recognition of the barriers sex workers face in getting police protection and accessing justice fuel physical and sexual violence against them. Furthermore, such violence by non-state actors is associated with STI and HIV infection and is a barrier to accessing health services. To be clear, even when lawfully applied, punitive laws impede sex workers' human right to protect their safety and health. This occurs on many levels, including preventing sex workers from screening clients, from negotiating safer sex, from working together, or from working from safer venues. Here we'll look at 2 ways in particular: the effects of arrest and displacement. So between 4 and 75% of sex workers reported having been arrested. And in 4 studies on 4 continents, experiences of arrest and imprisonment of sex workers were associated with unprotected sex, STI or HIV symptoms, or infection. Criminalization of sex workers or of their clients, and this includes contexts where clients are criminalized but selling sex is not, are associated with displacement to isolated and dangerous areas on the street. And where measured, police displacement on the street was correlated with experiences of violence and pressure not to use condoms. In the literature, one of the primary obstacles for sex workers to access care and ART, particularly if they are male or transgender, is discrimination and in many cases outright denial of care and treatment. Furthermore, contrary to UN human rights guidances, mandatory and forced HIV testing regimes for sex workers still exist in many regions across the world. Lastly, sex workers frequently face large-scale unlawful detention in so-called rehabilitation centers in a number of countries, including Thailand, Cambodia, and China. There are documented cases in the literature of unlawful detention for sex workers lasting months and even years without trial. Sex workers detained in police stations, prisons, or so-called rehabilitation centers are often systematically denied access to prevention and harm reduction tools, medical care, ART, and antenatal care. So there are many complex and hybrid legal systems for addressing sex work, and we chose to look at 4 common models and analyze them in terms of the evidence in the review. So to begin with, criminalization is the dominant global response to sex work. And under full criminalization, laws target individuals who sell sex, who buy sex, and third parties. Under partial criminalization, laws target some combination of those groups, but not necessarily all of them. The most severe and systematic rights violations in the literature occurred under systems of full or partial criminalization. In fact, criminalization often gave cover for widespread abuse, and yet even when lawfully applied, as we saw, punitive laws impede safety and health. A significant finding from our analysis regards the so-called Swedish or Nordic approach, where clients and third parties are criminalized, but selling sex is not. The finding that comes out of the evidence is that such approaches reproduce many of the same harms in terms of human rights violations and health as full criminalization. Where that approach is followed, sex workers are displaced to isolated and dangerous areas to evade police. The ability to screen clients is impeded. And furthermore, sex workers remain a party to a crime, resulting in police harassment and making it difficult to access police protection. Systems of legalization are generally, the first thing to understand is that their guiding goal is generally containment on moral or public health grounds rather than the promotion of human rights. And this helps explain why such systems are often highly restrictive, often discriminatory, and enforced with criminal law as opposed to occupational health and safety law. They often require mandatory health exams, which are counter to human rights, or public registration with no discrimination protections. And sex workers living with HIV are often specifically criminalized. Under the pretext of monitoring noncompliance, police raids and abuse can persist, and as is documented notably in Turkey and Hungary. In Turkey, police failure to investigate violence against sex workers remains a huge problem, and high levels of violence persist. Under the decriminalization model, human rights promotion of sex workers is a core goal, and it is the only model that has that as a core goal. If we look at New Zealand's 2003 Prostitution Reform Act that decriminalized sex work, research following the legal reform showed that, with over 700 sex workers, showed that they reported increased protections against violence. A majority reported increased power to refuse a client, increased power to report violence to police, and increased access to services. Decriminalization is the only model where there is evidence that the legal framework enhances sex workers' rights. Another thing to emerge is at the level of national and transnational policy, and it is the necessity to end the conflation of sex work and trafficking. This is not an evidence-based approach. And yet it has led to transnational policy that has fueled the criminalization of sex work and police raids, and has led to significant human rights violations as have been well documented, notably in Cambodia. Conflating sex work with trafficking failed to uphold the rights of both those in situations of trafficking and the majority in the sex trade who are not. It has further led to discriminatory policy in the form of the anti-prostitution loyalty oath in PEPFAR. And while that provision was struck down for American groups in 2013 in an important victory, it still applies to foreign groups and to the foreign subgrantees of American groups. The anti-prostitution loyalty oath is an example of a policy that is inherently discriminatory and also precludes our best HIV responses. Impunity is perpetuated not only through punitive law, but also through policies and practices. And so we need to decriminalize sex work, but we can also achieve meaningful change through reforming policy and practice. And though we need all three, if one is not possible in the short term, it is still possible to create meaningful change by working on the others. If we are to address HIV among sex workers, we will need to address the human rights violations against sex workers. And now for part two. Sorry, I was so thrown by the pediatric slides that I forgot to acknowledge my co-authors, and in particular the lead author on that paper who couldn't be here today, Michelle Decker. I'm now going to move forward with the call to action that comes out of all of the different articles in this issue. And so I'd like to start by thanking my colleagues, and a special thank you to the sex workers who worked on each of the articles presented here. So let me start by saying that sex workers are diverse. We are women, we are men, we are transgender, we are also trans women and sometimes trans men. Some of us are drug users, some of us are migrants, some of us are indigenous, and some of us are detained right now in police stations, prisons, rehabilitation centers, or migration detention centers. Some of us are in this room. In fact, we are everywhere. And everywhere we are, we have the right to security of the person, equality, liberty, and health. We have the right, whether HIV negative or HIV positive, to life. And yet, worldwide, we still face a disproportionate burden of HIV and a lack of access to treatment, prevention, care, and support. And this is in part because we still face a significant lack of funding globally for HIV programs for sex workers, and in particular for rights-based sex worker-led programs. Most of us live and work under the threat of laws and policies that criminalize and discriminate against us, and that challenge our ability to protect ourselves from HIV and to live long and healthy lives if we have HIV. There are important things we don't know still, such as what proportion of sex workers are accessing treatment if they need it, and when. And while there is great optimism regarding breakthroughs in HIV treatment and prevention science, none of these have been evaluated specifically for sex workers. We can and must do more. This map shows the global burden of HIV among women sex workers up through 2013. It does not include transgender women sex workers, so actually it is non-trans women sex workers. It contains data from 79 countries and 430,000 women. In white are the many countries, including the US and my own country, Canada, which do not collect data on the prevalence of HIV among sex workers. Sex workers with the highest burden of HIV are women in sub-Saharan Africa, and the combined prevalence of HIV across the sub-Saharan African region was 29.3%, or almost a third, with a 95% confidence range of 25% to 33.8% of women. All of the countries with prevalence rates above 50% are in Southern Africa. The high burden of HIV in sex workers globally, but particularly in sub-Saharan Africa, underscores the urgency of developing and funding programs to meet the needs and uphold the rights of sex workers living with HIV. Here are the prevalence rates by region, and next to the extremely high burden faced by women sex workers in sub-Saharan Africa, 5% or 4% may seem like very little, but bear in mind that that is still 1 in 20 or 1 in 25 women sex workers, and that is still hugely higher than women in the general population in these regions. As we just saw, there's incredibly scarce data about the extent of the burden of HIV among trans sex workers. Similarly, with male sex workers, there's incredibly scarce data, and male sex workers are often lost between studies on men who have sex with men and sex workers, and considered an afterthought in both of these kinds of studies. So what do we need and what do we call for? This Lancet issue calls for structural change, for the elimination of sexual violence alone in Kenya and Canada, as we saw, can avert 17 to 20% of infections over the next decade among women sex workers and clients. Decriminalization of sex work could have the largest impact on the course of HIV epidemics across generalized and concentrated epidemics, averting 33 to 46% of HIV infections over the next decade among female sex workers and clients. And so we call for structural and community-led interventions alongside biomedical ones to reduce HIV burden and to promote human rights for sex workers globally. In terms of prevention, we call for the scaling up of effective prevention measures, for meaningful engagement of sex workers in design and implementation, for the evaluation of HIV prevention tools, including PrEP, microbicides, and treatment as prevention specifically for sex workers. We call for access to ART for sex workers living with HIV, because we can't repeat it enough still. Access to ART is a human right. We call for ensuring that new biomedical technologies are voluntary and to add to, not replace, the basics. We call for responses where sex workers take collective ownership of comprehensive services. These are associated with a 32% reduction in HIV infection and a threefold increase in condom use. We call for the recognition of sex work as work and for the increased support of sex worker-led community empowerment efforts that integrate structural, behavioral, and biomedical elements. And say it with me, we call for nothing short of than the decriminalization of sex work. We call for an end to discriminatory, coercive, or repressive national or transnational policies and practices. We call for an end to impunity for violence and abuse by state and non-state actors, for access to prevention, treatment, care, and support, and we call for sex workers' involvement as partners in crafting law and policy on sex work. We call for improved data on HIV prevalence among male sex workers, informing evidence-based and human rights affirming services dedicated specifically to male sex workers. We call for an end to transphobia. For the decriminalization of, quote, cross-dressing, for legalization of appropriate identity documents, the provision of gender-affirming healthcare, the collection of quality data on trans sex workers, and the implementation of trans-specific, community-led combination prevention strategies. There are only a limited number of cost-effectiveness analyses, and these are of HIV interventions with female sex workers. We need more research on the effectiveness and cost of these interventions, and particularly for structural interventions and for emerging biomedical interventions, if these are found to be acceptable to sex workers, safe and effective. Estimates of cost effectiveness depend on a lot of things, such as local epidemiology and economics and study methods and the intervention itself. And yet, despite this variation, all of the interventions on this slide are cost-saving or highly cost-effective by WHO standards. The cost per daily is less than per capita GDP for the country. So the good news is, effective combination prevention and treatment approaches for sex workers are feasible, can be cost-saving, tailored for context and cultural competency, and can help address the unmet needs of sex workers and our communities in ways that uphold our human rights and work with us as equal partners. We urgently need to scale up these comprehensive services for transgender, male, and female sex workers around the world. Furthermore, we need more research in partnership with sex workers. We need to know what the HIV burden is among male and trans women sex workers. We need to know, are there any vaginal and rectal microbicides or PrEP agents that are acceptable, safe, and effective to sex workers? What proportion of sex workers with HIV are accessing treatment and care, and if not, why? We need to look at the effect of human rights violations on access to treatment for sex workers. We need to work with the community to do community-led participatory research to find out what is working. And we need to know what structural changes increase or decrease risk or access. What effect does decriminalization or a decline in police violence or community empowerment have on HIV risks? In sum, to address the burden of HIV on sex workers globally, we will need support for sustained community engagement and empowerment, continued research in partnership with sex workers, political will, and a little bit of moral courage to stand with us in demanding rights-based structural law and policy reform and innovative programs. Such actions can and must be achieved for male, female, and transgender sex worker communities everywhere. We cannot be left behind. We must start now. Thank you.